Zakaria. Dr. Zakia will be taking us on pharmacology of diuretics and cardiac glycosides. Dr. Zakia, you have 45 minutes to present. Thereafter, questions and contributions will come in. You can have the floor now, Dr. Zakia. Thank you.
Yeah, thank you very much. Good evening, senior colleagues and colleagues. I'll be taking us through the pharmacology of diuretics and cardiac glycosides. Sorry, please, can you see my slide?
Yes, we can see. We can see
I'm not able to move it.
Oh. Can you unshare and then share again?
Okay. Sorry, I can't see the option.
You can't do what, sorry? You can't do what? I didn't
the option to share.
Give me the extension box. You can't do.
Diuretics are medications used in the management and treatment of edematous conditions like congestive cardiac failure, chronic kidney diseases, and other non-edematous disease conditions like hypertension. Diuretics pharmacologically tilt the renal fluid regulation in favor of the excretion of water and electrolytes. That is, they create a negative feedback balance, thereby increasing the production and volume of urine. This class of drugs achieves this objective primarily by suppressing receptors, which aid in the reabsorption of sodium from the renal tubules, thereby increasing the osmolality of the renal tubules and consequently suppressing water reabsorption. So normally, in the Bowman's capsule, plasma from the renal artery passes through the three-layered glomerular ultrafiltration system and delivers an ultrafiltrate, which is isotonic to plasma. Then the proximal convoluted tubule reabsorbs about 60 to 70% of the filtered load, and this includes sodium, water, bicarbonate, organic solutes like glucose and amino acids, electrolytes, and some other substances. Such massive reabsorptive capacity occurs with the help of some specific transport receptors located on the brush border cells, which increases the surface area of the proximal convoluted tubules, yielding a fluid that is isotonic to plasma. Then from the proximal tubules, the filtrate passes to the thick ascending limb of the loop of Henle, where additional 25% of the filtered sodium is reabsorbed via a sodium-potassium co-transport system coupled to with uptake of two chloride ions. Their additional 5% of the filtered sodium is again reabsorbed in the distal convoluted tubule. Then from there, in the cortical collection ducts, the reabsorption of sodium is modulated by an aldosterone-sensitive mechanism, such that sodium reabsorption into the tubular cells leads to excretion of potassium and water and hydrogen ion. So water permeability and reabsorption in the collecting tubule are enhanced by the action of antidiuretic hormone, as well as osmotic gradients between the tubule and hypertonic interstitium. So this is a pictorial representation of what happens from the, we have afferent and efferent arterioles entering into the Bowman capsule. So this is the proximal convoluted tubule where the maximum reabsorptive capacity of the nephron occurs. We have reabsorption of water, ions, and some organic nutrients. Then from there, descending, we have the thick descending limb of the loop of Henle, and then the thin descending limb of the loop of Henle, followed by the ascending limb, and then the thick ascending limb. So this is a distal convoluted tubule collecting system, collecting ducts before it finally goes into the papillary duct. So we have different types or classes of diuretics. And the classification is based on the mechanism of action, anatomic location, anatomic site of action, and then the form of diuresis, whether it's solute diuresis or water diuresis that's it's caused. For the purpose of this presentation, I'll focus on the anatomic locus of site of action of the diuretics. So we have diuretics that act on the proximal convoluted tubule. This includes the carbonic anhydrase inhibitors, acetazolamide, and osmotic diuretics like mannitol. Loop diuretics, they act on the thick ascending limb of the loop of Henle. Examples are furosemide, torsemide, bumetanide, and ethacrenic acid. Thiazide and thiazide-like diuretics act on the distal convoluted tubules. Potassium-sparing diuretics act on the distal nephron, that's on the connecting tubule and collecting duct. So for the carbonic anhydrase inhibitors, we start with the proximal tubule. Sodium in the filtrate gets reabsorbed and enters the cell in exchange for hydrogen ion through sodium hydrogen exchanger, which is present in the luminal membrane and maintains electrical neutrality across the membrane. The hydrogen ion that reaches the lumen combined with filtered bicarbonate ion to form carbonic acid in the lumen. This is then broken down into water and carbon 4 oxide with the help of the enzyme carbonic anhydrase, which is present on the luminal side of the brush border cell. So the carbon 4 oxide that is produced from this breakdown diffuses back into the cell, and the water produced by the action of this enzyme it's also reabsorbed via the aquaporin 1 channels into the cell. So within the cell, they both recombine to form carbonic acid with the help of cellular carbonic anhydrase. So we have luminal and cellular carbonic anhydrase enzymes. Then almost 80% of the filtered bicarbonate is reabsorbed in the proximal convoluted tubules in this way. And this exits the basolateral membrane along with the sodium ion through the sodium bicarbonate co-transporter. And the sodium potassium, there's a sodium potassium ATPase pump, which depletes the excess cellular sodium ions along the basolateral membrane, and at the same time provides energy for the sodium hydrogen exchanger channel by creating low sodium levels inside the cell. So the renal reabsorption of bicarbonate and secretion of hydrogen ions play an important role in acid-base homeostasis and the steady maintenance of BP in the body. So this is what I explained earlier. We have the luminal carbonic anhydrase enzyme and then the cellular carbonic anhydrase. And then the action of this enzyme, it's potent. It's like accentuated by the sodium, this sodium hydrogen exchanger. So after dissociation of the ions, it's like transports the sodium and hydrogen ions into the tubular cells, just as I explained earlier. So the mechanism of action of carbonic anhydrase inhibitor, it's that it interferes non-competitively with both the luminal and the cellular carbonic anhydrase enzymes, and this results in impairment in sodium, bicarbonate, and water reabsorption. So although acetazolamide, the only medication in this group is acetazolamide, it targets the proximal portion of the renal tubule where the majority of the sodium ions undergo reabsorption. Compensatory processes also develop in the distal portions to reabsorb the increased distally delivered sodium ions. The physiological response of the body to compensate for this loss of bicarbonate ion is by decreasing the levels of carbon 4 oxide. That is by causing respiratory alkalosis. So this takes place by hyperventilation, which leads to increased expiration of the carbon 4 oxide, leading to higher partial pressure of oxygen in the arterial blood. So because high altitudes is a low oxygen environment, the action of acetazolamide decreases the incidence of tissue hypoxia in high altitudes, and therefore is the drug of choice, altitude sickness. Other indications for acetazolamide is glaucoma, and then it's used for treatment of idiopathic intracranial hypertension. So acetazolamide is well absorbed from the GIT, not metabolized, and then it's protein bound. 93% is protein bound in the plasma. The onset of action of the oral form is 1 to 1.5 hours, and it has an excellent oral bioavailability of about 100%. The half-life is 13 hours, and then because of this, twice daily dosing is recommended. Almost 90% of the drug is excreted in the urine via tubular secretion, and it's because of this is ineffective in patients with renal insufficiency. Side effects include hyperchloremic metabolic acidosis, hypokalemia, nephrolithiasis, and then it causes Fanconi syndrome because inhibition of the bicarbonate ion can also cause type 2 proximal renal tubular acidosis, which can lead to dysfunction of the proximal convoluted tubule, leading to drug-induced Fanconi syndrome. So other less common side effects are light-headedness, circummoral paresthesias, weakness, and confusion. Contraindications to the use of precipitate hepatic encephalopathy. It can also cause hyperchloremic metabolic. It's contraindicated in patients with hyperchloremic metabolic acidosis, and then caution should be it should be used in caution with patients with severe COPD. So drug interaction. Salicylates can displace acetazolamide from plasma protein, thereby causing an increase in free acetazolamide in the plasma, leading to toxicity. It should not be used to alkalinize urine following salicylate overdose because it can worsen metabolic acidosis in such cases. So the next is the loop diuretics. Let's look at the physiology of the proximal. It acts on the thick ascending limb of the loop of Henle. So the cortical proximal convoluted tubule descends into the outer medulla to continue as the thin descending limb of the loop of Henle, and ascends back as the thin and thick portions of the ascending limb of the loop of Henle before it finally reaches the cortex. So this arrangement is critical for the urine concentrating ability of the kidney, which is achieved by the countercurrent multiplier system of the loop of Henle. So in the thick ascending limb of the loop of Henle, we have the which reabsorbs 25 to 30% of the filtered sodium into the cells. The driving force for this action is the favorable low sodium concentration in the tubular cells achieved by the sodium potassium ATPase antiporter pump, which is present in the basolateral membrane. Excess chloride from the cells is transported via the chloride-specific channels and the basolateral side, which requires the beta subunits for their action. So we have renal outer medullary potassium channel, which is also present on the luminal side of the membrane. It secretes and recycles back potassium from the cell into the lumen with the help of ATP. So collectively, this not only results in creating a hyperosmolar medullary interstitial environment, but also creates a luminal positive charge that repels luminal cations, that is sodium, calcium, and magnesium via the paracellular pathway into the interstitium. The thick ascending loop of Henle is devoid of aquaporin channels, and therefore it's impermeable to water, and reabsorption of only the tubular solutes leads to dilution, resulting in hypotonic fluid within the lumen. And because of this, it's also known as the diluting segment of the nephron. The thin descending segment of the loop of Henle is permeable to water, unlike the thick limb. And the hyperosmolality in the medulla draws the water out of the segment through the aquaporin 1 channels, resulting in a hypertonic tubular fluid. So as the tubular fluid flows continuously in the loop, repeated actions of the thick and thin limbs creates an osmolar gradient within the medulla, with concentrations in the inner medulla that can reach up to 1,200 milliosmoles per kg of water. So the loop diuretics acts by blocking this sodium-potassium 2-chloride co-transporter channel. Blockage of this channel results in inhibition of sodium, potassium, and chloride reabsorption. This will lead to a reduced interstitial tonicity, thereby thwarting the countercurrent mechanism of urinary concentration. Within the lumen, the dilution function of the thick limb is compromised, and this results in excess sodium delivery to the distal tubules. And one will expect that there will be activation of the tubular glomerular feedback mechanism. So loop diuretics are the most potent among all the diuretics, as they inhibit the largest amount of sodium reabsorption. And because of the high efficiency of loop diuretics, they are also known as the high ceiling or high efficiency diuretics. Acute tolerance to loop diuretics occur within some time after dosing, and this can cause a breaking phenomenon. This phenomenon occurs as a result of rebound retention of sodium due to increased reabsorption of the distal of sodium from the distal tubules. At the same time, chronic tolerance can also occur due to distal tubular structural adaptation by the kidneys to increase sodium retention. So we can overcome the effect of acute tolerance to loop diuretics by choosing the correct dosage, adjusting the dosing frequency, especially in conditions like chronic kidney disease, the timing of diet, and then as well as dietary salt restriction. So chronic tolerance in heart failure may cause diuretic resistance, leading to refractory heart failure. And this can sometimes be overcome by increasing the dose of loop diuretics, addition of other diuretic agents like thiazide-like diuretics to perform in order to achieve sequential nephronal blockade. So this concept is very important because in patients with chronic heart failure, they because of the chronic tolerance to loop diuretics, they eventually become diuretic resistant, and there might be need for this sequential nephron blockade in order to achieve effect. So mutation in this sodium-potassium chloride channel can lead to type 1 Bartter syndrome, which is usually present at birth and is characterized by hypokalemic metabolic alkalosis, hypomagnesemia, and nephrocalcinosis. So loop diuretics are 95% bound to albumin. The peak concentration is achieved within 30 minutes to 2 hours. And then the oral bioavailability exceeds 80% for bumetanide and tosamide, while furosemide has a bioavailability of 50%. It's available both in the oral and IV formulation, and then IV infusion can also be used for immediate effect. Furosemide is excreted unchanged in urine or through a renal metabolism, while bumetanide and tosamide undergo hepatic metabolism. Tosamide has the longest half-life of about 3 to 4 hours. It also has the longest duration of action of 12 hours compared to furosemide and bumetanide. And because of this, the dosing is usually once daily. Absorption of tosamide is not affected by food intake, unlike furosemide and bumetanide, which decreases dramatically with food, and it's essential to be taken on an empty stomach. So for oral diuresis, the conversion factor, 80 milligrams of furosemide is equivalent to 20 milligrams of tosamide, which is equivalent to 1 milligram of bumetanide. While for the IV, 40 milligrams of furosemide is equivalent to 20 milligrams of tosamide. So loop diuretics are threshold drugs, meaning they no diuretic effect will occur below the threshold drug concentration. The frequency of dosing is also very important because loop diuretics that have a shorter duration of action can cause post-diuretic sodium retention, leading to antinatriuresis, as the diuretic effect usually wears off easily. So patients with CKD causes a diuretic resistant state, both by reducing maximal natriuresis, which will lead to a shift in the diuretic dose response curve rightward and downward. So this is a table just comparing the bioavailability half-life of tosamide and furosemide. So the side effects, they cause hypokalemia and metabolic acidosis, hypocalcemia and hypomagnesemia, hyperuricemia, hypertriglyceridemia, and hypercholesterolemia. They lead to ototoxicity. This side effect of ototoxicity is specific for loop diuretics. And the patient usually presents with sensorineural hearing loss, tinnitus, vertigo, and dizziness. It's usually dose dependent. They can also cause hypersensitivity reaction, such as skin rashes, acute interstitial nephritis, severe anaphylactic reactions. They are also a rare cause of Stevens-Johnson syndrome. Other less common side effects include photosensitivity, nausea. For furosemide and bumetanide, they displace bilirubin from albumin and thus lead to hyperbilirubinemia, leading to an increased risk of kernicterus in jaundice neonates. Rarely, it can also cause aplastic anemia and agranulocytosis. The mechanism is explained in the text. So drug interaction. The ototoxicity of loop diuretics become potentiated when combined with other ototoxic medications like aminoglycosides. Then the combination of hypokalemia inducible diuretics and digoxin can be dangerous when used in combination with loop diuretics. They are contraindicated in patients that already have gout because they can they also cause hyperuricemia. Then all loop diuretics, with the exception of ethacrinic acid, are sulfonamide derivatives. So they are contraindicated in patients that have allergy to sulfur agents. Hypokalemia, severe hyponatremia, hypotension, azotemia are also contraindication to the use of loop diuretics. And then any situation in which fluid depletion is foreseen, for instance, prior to maybe surgery, where we expect maybe the patient might lose blood. So loop diuretics should be used with caution in such situations. Furosemide and bometanide are pregnancy category C, while torsemide is category B, and it's relatively safe in pregnancy, unlike furosemide and bometanide. So thiazide diuretics, they act on the distal convoluted tubule. So let's look at what happens in distal convoluted tubule. We have the sodium neutral symporter that is expressed throughout the distal convoluted tubule. It derives its energy also from low cellular sodium ion achieved by basolateral sodium potassium ATPase pump. So these channels are the predominant mechanism for sodium reabsorption in the distal convoluted tubule. Reabsorption of sodium exits the cell via the basolateral sodium potassium pump into the interstitium, while chloride is transported to the interstitium via the basolateral sodium chloride cotransporter 4. Aquaporins are also, and because of this, they are also considered as the terminal diluting segment of the Neph1. So thiazide diuretics, type diuretics, and the thiazide-like diuretics. The thiazide-like diuretics are so-called because they lack the benzodiazide type agents. So for the thiazide-like, yes, can you hear me? Hello?
Your line, I don't know if I'm the only one, but your line is coarse. But just continue. Thank you.
Sorry. But can you hear me now?
Yeah, yes, you're much better. You can continue. Thank you.
So in the distal convoluted.
Hello, just 1 second. Page.
Sorry?
Sorry, there's one name I'm seeing on our call, and I don't think it's on WhatsApp page. Who is Jerry Martin? All right, go ahead. We'll just remove the person. Go ahead.
Sodium reabsorption occurs with the sodium chloride channel, and this is the target for the thiazide diuretics. So for the pharmacokinetics, all thiazide are sulfonamide derivatives. They are readily absorbed from the GIT after oral administration. The oral bioavailability ranges from 50 to 95%. And for the most frequently used agent, that's the HCT and clothianidone, the bioavailability is 70% and 65% respectively. So once in the plasma, thiazides are plasma albumin bound. and they do not undergo any metabolism prior to excretion. They are secreted unchanged via the urine and feces. The only exception to this is the indapamide, and less than 7% is excreted in the urine. So they have a half-life of approximately 42 hours. Sorry, clothalidone has a half-life of 42 hours and has a larger volume of distribution than its counterparts. Sorry, please, can you hear me?
Your line is breaking. It's breaking. Your network.
Sorry about that. So hydrochlorothiazide have a shorter half-life of about 6 to 9 hours. Then the side effects: hypokalemia, metabolic alkalosis, hyponatremia, hypercalcemia, hypocalciuria, hypomagnesemia, glucose intolerance, hyperuricemia, hypertriglyceridemia, and also, just like the loop diuretics, it causes Stevens-Johnson-like syndrome. Orthostatic hypotension and impotence are also rare side effects of thiazide diuretics. So for the potassium-sparing diuretics, they act on the collecting tubules. They act on the epithelial sodium channels. We have two types of potassium-sparing diuretics, firstly inhibiting the epithelial sodium channels, while the aldosterone receptor antagonists, they do so indirectly. So examples of the epithelial sodium channel inhibitors are amiloride and triamterene, while for the aldosterone receptor antagonists, examples are spironolactone and eplerenone. Spironolactone is non-selective. It mediates its effect through its anti-androgenic effects. And because of that, it can be in the treatment of androgen excess syndromes like hirsutism. And eplerenone is favored for the pharmacological treatment of primary aldosteronism due to its selective mineralocorticoid antagonism. So for the pharmacokinetics, the epithelial sodium channel inhibitors body, that's amiloride, while triamterene is metabolized into a sulfate ester by extensive hepatic metabolism. So in patients with liver pathology, amiloride is preferred over triamterene. However, amiloride must be avoided in patients with renal dysfunction because it is excreted through tubular secretion, and it also has a longer half-life. So the drug can accumulate in the body and predispose to life-threatening hyperkalemia. Amiloride, it's a pregnancy, it belongs to category B medication. It's safer to use for the treatment of Liddle syndrome in pregnant patients. Aldosterone receptor antagonists, spironolactone, largely undergoes metabolism in the liver into its active form, canrenone, which is more than 90% bound to plasma proteins. The bioavailability ranges from 60 to 90%, while that of eplerenone is about 69%. Food intake does not interfere with the absorption of these drugs, and taking it with food can reduce gastric irritation. So it's advisable to take it with food. The side effects. More generalized and less common side effects of potassium-sparing agents include headache, fatigue, GI disturbances like nausea, vomiting, constipation, diarrhea, anorexia, and abdominal pain. Side effects that are specific to amiloride and triamterene include hyperkalemia and hyperchloremic metabolic acidosis, while aldosterone receptor antagonists have specific side effects like gynecomastia. This is because of the non-selective antagonism. It's like, it has a structural similarity to progesterone. And because of this, it results in progestogenic and anti-androgenic effects, which block both the production of androgens and the binding of androgen to the receptors. So such a decrease in androgens will lead to decrease in androgen estrogen ratio. And because of that, it will manifest with the side effects of anastasia. It can also cause orthostatic hypotension. So I've mentioned this earlier, it's contraindicated in patients with hyperkalemia and advanced renal impairments. Spironolactone and triamterene should be avoided in pregnancy because they belong to category C. So the next is the osmotic diuretics. As opposed to other agents, osmotic diuretics do not interfere with electrolyte reabsorptive mechanisms. And their main action is mediated through increasing osmolarity of the tubular fluid within the proximal convoluted tubule, as well as the peak ascending limb of Henle. So the typical agent in this class is mannitol. It is freely filtered. It is a freely filtered non-metabolite sugar, which increases the osmolality of both plasma and renal tubular fluid, leading to osmotic diuresis. It raises the serum osmolality, and because it doesn't cross the blood-brain barrier, it creates a positive blood CSF osmotic gradients, and this is the mechanism. Mannitol is poorly reabsorbed, and it causes a washout of medullary sodium gradients, inhibiting the countercurrent urinary concentration function, thus allowing reabsorption of water within the collecting ducts. The osmotic effect of mannitol is similar to that of excess tubular glucose due to diabetes mellitus, leading to polyuria. It is poorly reabsorbed when given orally, and therefore it should be administered IV. IV is the only formulation that is available. Once in plasma, mannitol, being an osmotic substance, will draw fluid into the plasma, decreasing the blood viscosity, and thereby it can cause a false decrease in the hematocrit. Mannitol is freely filtered with limited reabsorption, and it undergoes only slight metabolism in the liver to glycogen. More than 90% is excreted unchanged in the urine, and the elimination half-life is about 70 to 150 minutes. Side effects, it causes hyponatremia, hypokalemia, nausea, vomiting, fever, confusion, leading to a lethargic state. This is just a summary of the different sites of actions of the diuretics earlier discussed. So we have some miscellaneous diuretics. This includes the sodium glucose co-transporter 2 inhibitor. It's a novel oral antidiabetic medication that inhibits the low affinity, high capacity SGLT2 receptor involved in the absorption of 90% of the filtered glucose along with sodium ions from the renal tubules and become overexpressed in patients with type 2 diabetic. So blocking this receptor will lead to increased excretion of glucose in the urine, thereby increasing the tubular osmolality, which will in turn cause osmotic diuresis. So this agent
sorry, Zakia, is it? Hello, Zakia, is it my network or maybe yours? Your voice keeps breaking.
Hello, sir.
I'm also experiencing the same thing, so I think it's from her angle.
Okay, Zakia, can you climb the mango tree close to your house? Is it possible? Or maybe change location? There's this mango tree. The mango tree in front of your house. Okay. Or network.
Yes.
It's
now I've changed my location.
All right, please, let's see how it goes. Okay. It's better.
Absolutely. So ACE inhibitors and ARBs, even though they are not strictly speaking diuretics, but they can also cause natriuresis and diuresis, primarily by blocking the production of the downstream molecules of the renin, angiotensin, aldosterone pathway. And they are involved in renal conservation of water and salts. So they can be used synergistically with other diuretics to improve or enhance diuretic effect. Alcoholic beverages, when consumed in moderation, can also cause a transient diuretic effect without causing electrolyte disturbance. So under conditions of hypohydration, alcohol does not induce any diuretic effect to restore fluid balance. We have aquaretics, the conivaptan, tolvaptan. They exert their effects by increasing only water excretion without any, they don't have effect on solutes. So conivaptan, it's non-selective, it acts non-selectively on the vasopressin receptor, both type 1 and 2 receptors, while tolvaptan is a selective antagonist of type 2 receptor. So ADH, adenine vasopressin agonist, they also lead to increased expression of luminal aquaporin 2 channels. So antagonism by aquaretics lead to enhanced aquaresis. That is, there will be like enhanced loss of fluid by these agents. So I will be taking from cardiac glycosides. Cardiac glycosides or digitalis essentially refer to a group of chemically and pharmacologically related drugs. They act on the heart by causing atrioventricular conduction and increasing vagal tone. They are invariably employed to slow the heart rate in atrial fibrillation and also administered in patients with congestive heart failure. So typical, hello? Sorry,
no,
please,
continue.
can you hear me?
Noise. It was background noise, just continue.
So we have more than 200 naturally occurring cardiac glycosides, and then they are derived from a diverse group of plants. The common source is usually Digitalis purpurea and Digitalis lanata. That's the fructose. Then examples of cardiac glycosides are digoxin, digitoxin, acetyl digitoxin, methyl digoxin, and deslanoside. It's The currently available form, it's only digoxin and digitoxin. So the mechanism of action, they bind to cell membrane and produce reversible inhibition of the sodium-potassium ATPase pump, which causes more sodium to remain within the myocardial cells and decrease potassium within the cells. So this increased intracellular sodium will stimulate the sodium-calcium exchange that brings, leading to influx of calcium within the heart cells. And this calcium influx will increase the force of contractility. That is, that's how it exerts its positive inotropic effects. Cardiac glycosides also have a vagotonic effect, that is, they stimulate the vagus nerve, which decreases heart rate by indirect parasympathetic stimulation with effect on the SA node and AV nodes, leading to bradycardia and variable degrees of heart block. It reduces catecholamine reuptake at nerve terminals, thereby rendering blood vessels more sensitive to endogenous and exogenous catecholamines. It also increases baroreceptor sensitization with consequent increase in activity of the carotid sinus nerve and enhance sympathetic withdrawal for any given increment in mean arterial pressure. At higher concentration, diuretics, digoxin or
Dr. Zakia, you
digitalis.
have 5 to 10 minutes left. You have 5 to 10 minutes left. Thank you.
So all this will lead to an increase in automaticity and slowed conduction. Hence, its antiarrhythmic or pro-arrhythmic effects, depending on the dose. So the bioavailability is 60 to 80%, onset of action 30 minutes to 2 hours per orally for initial effect, and then 2 to 6 hours for maximal effect. Duration of action is 3 to 4 days. It reaches serum peak concentration within 1 to 3 hours. That's the oral formulation. And then 20 to 25% is protein bound. Elimination half-life is 1 to 3 days. It's excreted in the urine and less extent in the feces and bile. So administration, it can be given, the IV formulation can be given with 5% dextrose saline, dextrose water, normal saline. It has a very narrow therapeutic index, between 0.5 to 2 nanogram per ml, and therefore its monitoring is very important for patient on digoxin. The toxic range is greater than 2 nanogram per ml. So this is it's used in patients with AF, refractory heart failure, when you've used optimum dose of the guideline-directed medical therapy, and there's no response. And then it's not recommended in patients with acute MI. It should be avoided in patients with myocarditis. There's risk of advanced or complete heart block in sinus nodal disease or AV block. And then digoxin should be withheld until toxicity. In patients that have previous digoxin toxicity, we have to monitor them and withhold the medication. Drug interaction, it's interact with amiodarone, atenolol, bisoprolol, and therefore dose adjustments is needed when used in combination with these drugs. So the side effect of digoxin, it causes dizziness, mental disturbances, GI disturbances like nausea, vomiting, diarrhea, anorexia. It can cause arrhythmia, heart block. It causes visual disturbances. Patients may present with blurring of vision or yellowish vision, the so-called xanthopsia. And then they could also have tachypsia, that is like appearance of zigzag lines to their vision. So it causes all forms of arrhythmia. The most common form of arrhythmia caused by digoxin is ventricular bigamy. So in patients with digoxin toxicity, ABC of resuscitation should be instituted. Then the specific drug of choice is usually the digoxin-specific antibody. That's the FAP fragments. So risk factors for digoxin toxicity include renal impairment, elderly, hypothyroidism, hypoxia, hypokalemia, hypomagnesemia, and hypercalcemia. So in the indications for use of this FAP fragment, it's in patients with severe digoxin toxicity, patients with hyperkalemia, patients with life-threatening or hemodynamically unstable arrhythmia, and organ dysfunction from hypoperfusion, or when the serum digoxin is greater than 4 nanogram per mils. In conclusion, cardiac glycosides are in common use and may be accidentally ingested. They have a narrow therapeutic index, and therefore close monitoring is important. They can cause life-threatening arrhythmia if toxicity occurs. Thank you very much for listening. I'm sorry for the hitches in network. These are my references. Thank you.
Thank you so much, Dr. Zakia, for this excellent presentation. We appreciate the effort. Thank you so much. So we would go in an ascending order. We'll start with the participants. Thereafter, our chiefs will then ask their questions and then make their contributions. So I think we should appreciate her efforts in the chat room. So before the participants start asking their questions, I would want to ask my own question. Okay, Dr. Zakia, you made mention of torsemide being safe in pregnancy. Okay, so does it mean that a patient with heart failure in pregnancy, it's safe for us to give torsemide to such a patient? Hello, Dr. Zakia. Hello, Dr. Zakia.
Yes, can you hear me?
Yeah, I can hear you.
Yes, it's not contraindicated in pregnancy, but it should be used with caution because it can cause placenta insufficiency, which will be detrimental to the fetus. It belongs to pregnancy category B. It's just comparing it to furosemide and bumetanide. It's relatively safer than furosemide, but that doesn't mean it's safe. It can cause placental insufficiency.
Okay, so that means from all the loop diuretics, the safest to give a pregnant woman is torsemide. Though we have to give all of them with caution, but the safest is torsemide, right? Okay, thank you. All right, so my second question is, I didn't really get you made mention of the potassium sparing diuretics. You made mention of the aldosterone receptor antagonist, where we have the spironolactone and the eplerenone. So for the amiloride and triamterene, I didn't really get the class of drug you tagged it with, like what you named the amiloride and the triamterene medication. I don't know what exactly you mentioned as that particular class. I don't know what class is amiloride and triamterene on that, but I didn't get it, sorry.
Thank you. There are also potassium-sparing diuretics. So this potassium-sparing diuretics, they act on the aldosterone-sensitive distal nephrons. It's a collection of cells within the distal tubule. It comprises of the late distal convoluted tubule, the connecting duct, and then the connecting tubules and the connecting duct. So we have two types of potassium-sparing diuretics based on their mechanism of action. We have the epithelial sodium channel inhibitors, under which the triamterene and amiloride falls, and then the aldosterone receptor antagonist, under which we have spironolactone and eplerenone. So for the epithelial sodium channels, they act directly on the aldosterone sensitive cells. They exert their action by binding directly to the epithelial sodium channel receptors within the cells. While for the aldosterone receptor antagonists, they bind to mineralocorticoid receptors. The binding to these receptors will lead to indirect suppression of aldosterone-induced protein. In short, they exert their effects indirectly, unlike the epithelial sodium channel inhibitors, which acts by binding directly on the receptors. I don't know if it's clear.
Okay, no, it's actually clear. Thank you so much. Okay, then my third question is about, in the when we were talking about the digoxin, you talked about both hypokalemia and hyperkalemia. So does it mean that when the potassium is low and when it is high, digoxin is actually contraindicated? That's at both extremes. I don't know, because that's what I saw there.
Okay. Yes, for patients with hypokalemia, they are at risk of having the digoxin toxicity. However, if the patient is on the digoxin, we still need to maintain the serum potassium level to within the normal reference, because we also don't want the patient to have hyperkalemia. It doesn't lead to digoxin toxicity. The risk for digoxin toxicity is hypokalemia, but because hyperkalemia can also lead to, especially in patients with renal impairments, it can lead to fatal arrhythmias. But the hyperkalemia I put under this slide, I think, is a topographic error. Hypokalemia is the risk for digoxin toxicity.
Okay, thank you. Okay, thank you. So, then what's your take on the combination of digoxin and amiodarone? Because you made mention of, I don't even know what I saw there. So can we give digoxin and amiodarone, or if the digoxin is not doing what you want, maybe you now have to stop and then step up to amiodarone? Can we give some of them in combination? And what is the patient at risk of if we give both of them together? So I don't know, because I think I saw, I don't know if you can highlight a little about those two drugs given together. Thank you. That's my last question. Thank you.
For the question, amiodarone will increase the serum digoxin level, and so it will increase the risk for digoxin toxicity. So whenever, I don't know indications for combination of digoxin and amiodarone at the same time, but I know that amiodarone lead to digoxin toxicity because it increases the level of digoxin, serum digoxin. The same thing applies to verapamil, flecainide, and propafenone. So the use of this antiarrhythmics in combination with digoxin, it's not really advisable. I don't know if there's anybody that can shed more light on this.
I think both of them shouldn't be given, because it will worsen, it will suppress the conductive system. It can lead to blocks, you understand, in patients. So I don't know, but our seniors can actually add to that. I think I glossed through somewhere where they said it's not advisable to give both. If you can't achieve what you want to achieve with the digoxin, then you have to stop with the digoxin and then go higher to amiodarone, because it can depress the conductive system. It can lead to blocks, conduction blocks, and all. So I don't know. Thank you. That's what I can say about that. All right. So we would go over to the chat room then. Dr. Sambo, you'll be next to ask a question. So Chief Okopi is saying excellent presentation, very detailed. Dr. Siri was okay. He's saying thank you very much, Dr. Zakia. Dr. Chief Itsubi is saying thank you for the excellent presentation, Chief. Okay, so Dr. Zakia, I can see your electronic hand up. I think you can ask a question. Thank you. Dr. Sambo, you have the floor, please, Dr. Sambo. Dr. Sambo?
Dr. Sambo is out, so probably you give it to Dr. Sorry Conte. Conte, please, you can unmute and speak. Then afterward,
yes,
we'll take comments from Alexi to be Alison, and then the chief. Our chief is around. Dr. Prof is around.
yes.
Welcome, sir.
Okay, can I go ahead?
Yes, you can, Dr. Curry.
Yeah. So thank you very much, Dr. Zakia, for a very extensive presentation. Although along the way, I got a little bit lost. I was finding it difficult a bit to follow the slides. And in that regards, I want to appeal, Dr. Zakia, before you share the slide with us, if you can work a little bit on the slides to make them clearer. Would appreciate that a lot.
Yes,
I want to make a contribution concerning the acetazolamide, the carbonic anhydrase inhibitor diuretic. So recent studies have shown them to be useful in acute heart failure. So it's called the ADVOR trial, where they use 500 milligrams of acetazolamide in addition to the usual furosemide for fast relief of congestion and edema during acute heart failure. Okay, so it was not shown to improve mortality, doesn't have any mortality benefit, but resulted in quicker diuresis and quicker decongestion of the patient. And that was included actually in the 2023 update of the 2021 ESC guideline. So that's something that we should take note of. I did not quite hear you mention, I don't know if I missed that, mention metolazone as part of the thiazide-like diuretic. And I was just wondering, among the thiazide and thiazide-like diuretics, they are used more for for treatment of hypertension rather than their diuretic effect. But when it comes to metolazone, it's the reverse. It's a more potent diuretic. And I stand to be corrected, but I've never seen it used as an antihypertensive. I don't know, is there an explanation for this, vast difference between the usual thiazide and thiazide-like diuretic when it comes to metolazone? Thank you.
Thank you very much, sir, for the contribution. I mentioned it was part of the slide. I just listed the thiazide-like diuretics. I listed metolazone as part of but the font size is actually small. I will adjust the slides before sending to the group. The reason why metolazone it's more of a potent diuretic than an antihypertensive, I'm not really sure. I'm not sure, sir. Welcome contributions. Hello?
Okay. Maybe when we get to our chiefs, because we're doing it in an ascending order, maybe they'll contribute to that. Thank you, Dr. Zakia. Thank you so much. Okay. All right. So, Chief Etsubi, I think you can have the floor. Thank you. You can ask a question. Thank you.
Okay. Thank you very much, Dr. Florence. Thank you, Dr. Zakia. Good evening, consultants, senior colleagues and colleagues. I wanted to make a comment on the question Dr. Florence asked about hypokalemia, and hyperkalemia. So because digoxin is primarily cleared by the kidneys, so when we have a decline in the renal function, it can cause chronic toxicity. So it's very important that renal function is assessed, but not just renal function. Electrolytes are also very important to be assessed, because hypokalemia, hypercalcemia, hypomagnesemia, they are known to worsen the effect. Now, because of the way digoxin acts, it is a sodium potassium ATPase inhibitor. So that also can lead to hyperkalemia. So that's where the hyperkalemia, I think, on the slide comes in. And that hyperkalemia can actually be a marker for toxicity severity. So it's not just hypo, but hyperkalemia can be seen as a marker of toxicity severity because of its effect in blocking sodium potassium ATPase. Then patients who are on this therapy ideally should have serial ECG monitoring performed and continuously, just to look out for fluctuations in terms of their reading, because they can have different kinds of arrhythmia, like Dr. Zakia mentioned earlier. So, and sometimes when you do the ECGs, you can find what is called the digitalis effect, which means that clinically the patient may not have side effects of digoxin toxicity, but ECG changes can be seen. And usually those changes involve the T wave, which could be either T wave flattening or inversion, or what is known as the scooped appearance of ST segment, or even ST depression, can all be seen in such patients. So when we see that on ECG, it must not necessarily mean that they may not have clinical signs of toxicity, but that's what's known as the digitalis effect. Thank you.
Thank you so much,
Thank you very much.
Chief. Thank you so much, Chief Etubi, for that brilliant input. Thank you so much. All right, Dr. Sambo, you can have the floor.
Actually, Dr. Etubi, well, you said one of the things that I wanted to, but regarding the mechanism of arrhythmia with digoxin,
Dr. Sambo, you're distant. You're distant. Dr. Sambo, you're distant. You're not audible enough.
Can you hear me now?
Not so much. I think you can make it louder.
Can you hear me?
Better. Thank you.
Okay, so I said another mechanism aside the increased automaticity for digoxin toxicity is delayed after depolarization. Okay. And then regarding the mineralocorticoid receptor antagonist, there's another one. It's not just the epredinone and the spironolactone. So we have finrenone, which is a class 1 indication for patients with heart failure and CKD and type 2 diabetes. So thank you very much for your presentation, Dr. Zakia. It was really great.
Thank you so much. Thank you so much, Dr. Sambo, for that great input. Thank you. All right, so we'll go over to the chat room, and then Chief Adeyanju is saying, well done on the lucid presentation. Kindly note to differentiate between digoxin toxicity and effect.
Dr. Florence.
Yes, sir. Yes, sir.
Please, can we give Dr. Adeyanju the floor to speak so that she can just say it into the...
All right. Okay, thank you.
So after Dr. Adeyanju, we'll go to Dr. Allison, then from Dr. Allison, Uzoke, if you have something, please, then we'll call on Prof to wrap up. Thank you. Dr. Adeyanju, over to you.
Hello, everyone. Good evening. Thank you so much, Chief. Good evening, Professor. Sorry, it's because I was multitasking, but I'll quickly run through this. Thank you, Dr. Zakia, for your presentation. Digoxin is a very, very important topic, and it has come out in the oral exam, I think like 3 times now. So we must know a little bit of the history that is from first love, the Lanata. But to go specifically to the questions that have been asked, we have the digoxin toxicity and we have the digoxin effect, and we have to differentiate that. Sometimes you see the effect on the ECG, and that's what Dr. Etube has been trying to say. It talks about they call it reverse tick sign. Sometimes you can also see some tachycardia there. However, I think the most significant feature of the toxicity on ECG is the biventricular tachycardia, if I remember very well, which is also seen in CPVT. So we have to note that. However, we can see any feature of digoxin on ECG, from tachycardia to tachyarrhythmia, but they've talked about the most significant one, which is the biventricular tachycardia, if I remember very well, is also seen in CPVT. Apart from that, when we look at the mechanism of action of digoxin, yes, bidirectional tachycardia, thank you. When we look at the mechanism of digoxin, it inhibits sodium potassium ATPase. And when it inhibits, it drives potassium out of the cell where sodium enters the cell. This in itself can either cause hypokalemia or hyperkalemia, because if you inhibit that effect, you can have hyperkalemia, and if there's hyperkalemia, you can also have digoxin toxicity. Another thing in digoxin is that we must note that it can affect all the system. So we must have at the back of our mind, we are doing cardio, know the cardiovascular effects, know the CNS effect, know the GIT effects in that order and in that manner. It is very, very important. Then another important part of digoxin is the treatment. How do we treat it by toxicity? Have we seen the DigiFab before? How do we calculate? If it's an acute toxicity, how many milligrams do we give? If it's chronic, how many milligrams? If it's an adult, if it's a child, how many milligrams do we give? I think they used to give 20 milligrams, but I need to check that one to be sure. But another important thing is that in heart failure patients, they used to say that it should be between 0.9 nanogram to 1.0 nanogram. However, you personalize the treatment of every patient, because if they have other comorbidities, maybe renal disease, as Dr. Etube have said, if they are on other drugs that have already caused electrolyte derangement, if they are elderly, or if there are other any other comorbidities, it could actually affect the time, and toxicity may be higher in some people more than the other. So you personalize their treatment. So when you have an heart failure patient on digoxin, ideally you should actually evaluate them every time they come for follow-up, maybe every 2 or 3 months. Look at their electrolytes again. Look at what might cause either a toxicity or digoxin effects in them, and personalize their care. Then there is digitoxin and digoxin. For digoxin, which is, I think, what we are talking about now, is what we usually prescribe. But when we have digitoxin in patients that have renal kidney diseases, in which that you have to the mechanism of the element, the route of excretion is mainly through the renal system. I think about 90%. You can give them an alternative of digitoxin, which is actually eliminated in the hepatic system. But I might need to also cross-check that. But sometimes when you know that, oh, this person has a CKD, and you weigh the benefits and the risk, you can actually give them the alternative rather than giving them the digoxin. But there are differences between both of them too. I think that's what I can recollect for now. Thank you very much for the opportunity.
All right, just thank you so much. Dr. Florence, just hold on. Let me just call on we have Dr. Jima. Dr. Jima will be seeing you, and is one of the founding members of this class, and he's been joining. So probably, please, after Uzoke and Alison speaks, you speak before Prof comes up. Ayodeji, if you have anything to, you can speak in between. So Uzoke, please, if you have any comments from exam, because this glycoside came out in my own exams, and it's been repeating itself. Ayodeji, Uzoke, and then Alison before Ojima, then we'll call on Prof.
Thank you, Chief. Thank you, Zakia. I think the presentation was quite extensive. There is no much comment to make other than to thank the presenter and equally to remind the presenter about the comment of content. Most of us are squinting to see the slide. If you can just make it about 7, 8 lines per slide, that would be wonderful. Be appreciated. I think that should be that for now. Thank you.
All right. Ayodeji, do you have anything before we go to Alison? They will call on Ajaya.
Okay, I think I already deposited in the box. I said there is not diagnosable too. So it has a small volume of distribution too. That's why. And it has to be used with caution in patient with amyloidosis, because it increases the avidity of the amyloid tissue, increases its avidity to tissues, so they are more prone to abnormality of cardiac arrhythmias, and that could also lead to compromise. So it should be used with caution. And then that's it.
All right. Thank you so much. Thank you. So, Alison, over to you, please, before for Ajaya, then Prof.
Okay, thank you. Good evening, Chief. Good evening, everyone. Thank you, presenter, for the presentation. It's to take the two topics actually. I must credit your efforts. Thank you so much. Digoxin, it's let me say, it's a drug that you must know in and out for exams, both for MCQs and for OSCE questions. So maybe we should pay more attention on the mechanism of action, which is what Dr. Etubi mentioned. Sodium potassium ATPase, you can find out in exam. And what it does is that the inhibition of that ATPase, and when that happens, it promotes sodium calcium exchange, really. So you know the ATPase, that means the there will be, if there is hypokalemia, it means that there will be toxicity, because it will give enough room for the digoxin to actually bind to the ATPase, that's the receptor in the transport system. So that's why when you have hypokalemia, the receptor is left bare open. So it gives it the digoxin enough room to bind to that receptor and will lead to toxicity. On the other hand, for the hyperkalemia, you know, when there's digoxin toxicity, that means the electrolyte does not have enough room to bind to that receptor. So it's now lead to hyperkalemia. So that's just the explanation. So hypokalemia will enhance digoxin toxicity, whereas digoxin toxicity would actually lead to hyperkalemia. That's why it must be used with caution. The same reason why it must be used with caution in patients who have abnormality with the excretion or the metabolism or exchange of potassium. So you should have that in mind. Another thing is besides that's the primary mechanism of action of digoxin. But the second mechanism of action will be that it has parasympathomimetic action by increasing vagal tone through the SA node and also AV node. So it will now lead to a decrease in heart rates, and it will slow down the AV conduction. That's why it must be used with caution when you are using it together with medications that will slow conduction, or with medication that will affect the atrioventricular load conduction, like beta blockers, amiodarone. As we know that amiodarone will equally block atrioventricular conduction, leading to bradycardia. So in digoxin, other adverse effects of digoxin could either be a tachyarrhythmia or a bradyarrhythmia. So it could have tachycardia or bradycardia. So when we have tachycardia, the treatments actually, okay, we've all been talking about digoxin and the digiband, yes, it's good, but in exams, they might actually want to hear something other than that because we don't have it in our environment. How many people have seen it? So you must mention phenytoin. That's what they were using before. Even in Nigeria Connect, I'm not sure if I've never seen digiband before, but the profs and professors will actually want you to mention phenytoin in case of tachyarrhythmias. Now you can give that while you source for whatever. And when is bradycardia, in that case, what you use is atropine. So we should please take that into consideration. And Dr. Ayodeji has mentioned some of the things I would have mentioned. It's good to know that digoxin is not dialyzable. And the reason why it is not is because it is about 20 to 25% bound to plasma, and it has a large volume of distribution. So dialysis will actually not work. So for MCQ purpose, we should know that it is 20 to 25% bound to plasma. It has a large volume of distribution. So we should also know that it's not dialysable. Another thing is the metabolism of digoxin. Yes, we know that it interacts with so many drugs, but it's still not dependent on the cytochrome P450, in case we see it in MCQ. So the metabolism is actually not dependent on cytochrome P450, rather by all these hydrolysis, oxidation, conjugation by the liver, although excreted by the kidney. So it might be a tricky question for MCQ. So cytochrome P450, no, in case we see it in MCQ. Then another thing would be that for concomitant medications that we use with digoxin, we should be aware of all drugs that interact with digoxin. Really can come out in MCQs, and you should know those that will increase digoxin serum concentration and those that will decrease digoxin serum concentration is actually important. Like we have emphasized, amiodarone will increase serum concentration of digoxin. Other medications like itraconazole, macrolide, NSAID, we should please check them up for MCQ purpose. Even verapamil will actually increase digoxin toxicity, and spironolactone too, tetracyclines. We should please look for tables that would, maybe someone will post that will make it easier. You must just, in a way, try to cram all those stuff for MCQ. And those that will decrease, we should also antacid, phenytoin, rifampicin, and neomycin. Those are the few I can remember now that I crammed for exam. So we should please note that. And we've mentioned concomitant use of some drugs. Beta blocker, important. Sympathomimetics, important. Amiodarone, important. So we should know that concomitant use and what the effects will be. Might be there's a way they could twist the questions for MCQs, really. And what else? I'm not sure if I can remember any of that thing now. I think that's all I will say for now. Thank you so much for the presentation. Yes, before I leave, digoxin, yes, someone has mentioned digoxin and amyloidosis. The reason also being that the exact spots where we have digoxin binding to will be the same place where it will, let me just say, digoxin will displace the amyloid, what do we call it now? Amyloid, there's a word that I'm looking for, leading to digoxin toxicity. That's we call them the amyloid
fibrils.
Yes, exactly. So it will cause toxicity. So it's actually contraindicated in amyloidosis. Other situations where it must be used with caution, if possible, don't use at all, will be other restrictive lung diseases, Fabry disease, HCM, as it may be in HCM. You preferably use amiodarone if you are finding it difficult instead of digoxin, really, because it will worsen their symptoms. They don't really cope with it. So HCM, fibroids, and amyloidosis, we should be cautious in using. In fact, digoxin is contraindicated in most of all the ones that I've mentioned. I think that's all I can remember now. Digoxin and warfarin too. We should please check up the interactions. They could ask in MCQ questions that will it increase, will it worsen, all this, the way they just, so we should please digest digoxin very well. Digoxin and amyloidosis, digoxin and warfarin, digoxin and amiodarone are beta blockers and some other medications. Thank you.
Thank you so much, Dr. Florence. Dr. Zakia, please, I don't know if you are noting some of these stuff so that you can update your slides before you send them. Dr. Zakia, are you there?
Yes, sir. Yes, sir. Thank you very much for the contribution.
Please just note them so that you can update your slide before sending them. All right. All right. Let me welcome Dr. Ojima Ajaya. Ojima Ajaya, please.
Good evening, Chief Okopi. Good evening, everybody. Good evening, Prof. Thank you, Dr. Zakia, for the presentation, and thanks for all the wonderful contributions. A lot has been said already. I don't want to repeat anything, but I think just to comment on the issue of use of diuretics, methylazone as antihypertensive, or in whether it's used in conjunction with for diuretics. It can also be used as an antihypertensive, just like the other thiazide, just like even nitrilics. You can also combine either the nitrilics or hydrochlorothiazide with your furosemide to potentiate diuretics. So also metolazone is also a very useful antihypertensive. We use it a lot in our patients with kidney failure. In our nephrology unit, they use it quite often too as an antihypertensive. So it's also a very good antihypertensive, despite the fact that it has diuretic effect. Then just to add to the discussion on the digoxin, I don't know whether I joined it quite late. Also, the age of the patient is important in terms that elderly people are more prone to digoxin toxicity compared to younger people. So it's good to evaluate the patient properly before you start the patient on it. And also to mention that it's still a very, very useful drug in terms of helping to reduce morbidity in patients. Thank you.
Thank you so much, Chief Ajaya. Always pleasing to have you on the call. So we'll give the call now to our Prof for always being around. Prof, sir. Thank you so much, sir.
Well, thank you, everyone. It has been a fantastic presentation, Chief Okopi. Chief Ajaya, it's good to hear your voice again. Great. So it has been a fantastic presentation. So I don't really have much to add. I think it has been well scrutinized by every of the comments presented on this platform. And thanks also for discussing metolazole. So one benefit of this metolazole is that it's work effectively as an add-on when patient has resistant edema. So either he has heart failure and they have this recalcitrant edema, and you're already getting to the maximum dose of your loop diuretics, metolazole comes in handy to help resolve this fluid overload. As Dr. Jan said, it can be used even as the diuretic of your antihypertensive. So there's no catch to it at all. But we just preserve it for treating of recalcitrant or resistant edema, either in heart failure or in kidney disease. So the number 2 important information regarding the digoxin and amyloid is in fact, Prof, our chief examiner just likes that question, amyloidosis and digoxin. So it's important to study the relationship between amyloid and digoxin. One important information you should have is that since we all know that amyloid can be associated with conduction abnormality, either it is third degree block or any of this conduction abnormality. Digoxin also is a medication that can also result in conduction abnormality. So you can see that digoxin can potentiate the arrhythmias, the conduction abnormality arrhythmias that can be seen in amyloid, apart from other toxicity that can happen in that condition. So in case you are asked in the Viva station, I think you should have that information very handy. The last information you should also understand is that there is room for combining 2-3 diuretics. There is actually room for combining 2-3 diuretics. As Dr. Jaya said, if the patient is on indapamide, you can combine it with your loop diuretics. There is a physiology behind it. And the main physiology behind it is the site you are targeting on the nephrons. So if you use loop diuretics, then you're only targeting the loop of Velin, especially the ascending loop, thick ascending loop of Velin. So if you now combine it with your thiazide, that one is in distal tubules. So it simply means that when you block the ascending limb, there will be, even if you block the absorption at that sodium absorption at that level, the sodium overload at the distal convoluted tubule can now be overabsorbed by the distal tubular cells. So in order to avoid the repercussion of excess absorption, that is why you can block at both sites, the loop and also at the distal convoluted. So that's the physiology behind it. And why is it that most of the time we don't use acetazolamide? It's not an effective diuretic agent. It's because it works at the proximal convoluted tubule. So if you block the absorption of the electrolyte at proximal convoluted tubule, what will happen is that by the time the electrolyte is getting to the loop and distal convoluted tubule, it will be absorbed. So whatever effect you think you have achieved by blocking the absorption at the proximal convoluted tubule will be nullified by the time you get to the loop of Velin and also the distal convoluted tubule. So it's best that this blockage should be done at more distal end, which is the loop and the distal convoluted tubule. So that is the physiology behind combining the medication. So there was an article, there was a trial that showed the effect of acetazolamide as an add-on in heart failure patients that are already on other diuretics. And it actually showed it actually reduced morbidity, but not mortality. It reduces the rate of hospital admission. But if you had just used acetazolamide alone, that'd be an issue. Then the effect will be nullified because the other segment of the nephrons will absorb whatever has been blocked at the proximal tubule. So just wanted to buttress the question Dr. Conte asked and the response given by Dr. Jaya. Okay, so nice presentation and it's fantastic. Thank you very much.
Wow, thank you so much, Prof, for always coming around. And thank you, Ajaya. Thank you, all our various colleagues. I'll hand over now to the class rep to continue the other phases of the discussion. Dr. Florence, over to you.
Okay, and thank you so much, Chief Okoki, for moderating, for making it easy for me. So it's been a richly packed night. I also want to thank our seniors who have made great inputs. We really appreciate your presence and we know you keep coming. Thank you so much. All right. Thank you so much, Dr. Zakia, once more again for that excellent presentation. So move over to the second section of the day, which is the MCQs.